I'm the Service Improvement Manager in Medical Imaging, and I am here with John Shaw today, who is going for his Practice Coach certification on his project. We are recording this prior to report out, as John is actually on nights this week, so hence the reason for this recording. So hi John, thanks for taking the time to talk today.
Hi Kerry, thanks very much for having me.
Not a problem. So I'm going to go to the first slide, which is obviously your 8-step here. So just wondering if you could tell us just a little bit about your project. What was your motivation for getting it started, and how did this all come about, really?
So yeah, of course. So prior to working here at Derriford, I worked in a different trust where we did perform CT colons, but I didn't appreciate how much positive change could be achieved in this until I started working here at Derriford.
Brilliant. Okay. So what if we were to understand this project, if we knew nothing about it, and you were just going to describe us as the benefits on a page, what do you think are really the benefits to the patient by doing this, and also what are the benefits to the organisation?
So for me, patients being seen within their 10-day target, so for 2-week wait patients being seen within their 10-day target potentially increases the likelihood for diagnosis and subsequently treatment. We're intending to optimise patients' flow through their care pathway. So although being in imaging, we don't own their pathway, we're one of their first and key steps in their journey. So I think in terms of benefits to the organisation, even though we don't own their pathway, we're able to proceed as a contributor.
Yeah, definitely. I think that's a really, really valid point. And obviously, just looking at the organisation as well, I think it was quite high profile, wasn't it, that we were having problems with CTC compliance for quite a while. I mean, prior to COVID, the demand was so high, and obviously we shut it off in COVID for a previous time. And I think, did we convert to TAPS?
We did, which obviously did bring up all sorts of other issues, because then we did have some people coming back who had CT TAPS or CT abdo-pelvises, because they still needed the bowel prep and they still needed to look inside the large bowel. So it helped some people, but I think for some people they just ended up getting multiple scans. So
definitely. And I think what happened after that was that the demand kind of trickled back in when we turned back on to CTCs, and then it just came straight away, and we were really having problems with that compliance. So I think also as well, I know when we spoke about this project, that was another big thing that we were really keen to get started on, wasn't it? Which was, how could we make this sustainable and resilient for future demand that we were going to get post-COVID?
Yeah, absolutely. Yeah, absolutely.
Definitely. So do you want to tell me about how it started? Because this is a massive project. So what was the first step you took?
Yeah, so I spoke to Colin, the boss, and he advised approaching you in service improvement, and we had quite a lengthy Teams meeting discussing the hidden potential, if you like, within the CTC service, and the fact that people have definitely tried to. I know it's been an issue for a while. I think it's been mentioned at care group level as a somewhat of a problem. So we thought it was something that we could really fix. There's lots of stuff that we could do to change it and fix it, and just ultimately make it the best for the patients.
Definitely. And yeah, talking about that Teams meeting, like you said, I can remember when we first started talking about it, it was clear this was going to be a massive project, and you obviously had such creative thinking ideas and some really good ideas of how to get it started, which is obviously going to lead me on to my next question for you, because we've identified this all along as an agile project, something that we're going to need to change the goalposts as we go along. So how did you break it down into key areas that needed to be improved rather than tackle it all in one go?
Yeah, so we have three main areas that we sort of looked at. So capacity, referral quality, and also our prep. So in terms of capacity, to start with, the demand from our 2-week wait referrals was at one point outstripping our ability to scan by as many as 5 per week. So that's not even including the urgents and our routine CTCs. So in terms of our prep, our bowel preparation, so we were using Picalax along with gastrografin, and we carried out a trial, and I performed an audit to determine whether diagnostic quality dropped. And in terms of referral quality, this is a bit of an ongoing process, and there are quite a few referral routes into CTC, and the quality is not helped by our straight-to-test and telephone consultations. During COVID, obviously, these face-to-face assessments have generally stopped, and it affects a consultant's ability to determine physical and mental suitability for the procedure. So that's something that we want to look at and address as time goes on.
Definitely. So just mentioning there about your prep audit, are you just able to just give us a little bit more information on that? Where did you present it to? And just basically for information, I guess, how did you win people over, if you see what I mean, to changing a process which had obviously been in place for quite a long while?
Yeah, so I was in a sort of a fortunate position. So in my previous trust, we didn't use any sort of laxatives. We just used the gastrografin because it has a purgative effect in the bowel. So I was in discussion with one of our GI radiologists who I previously worked with at another trust where we'd done this, and we had decided that we would trial it and see if we could get positive results. And after I'd done my audit, I presented this to the GI radiologists. They were very receptive. It's very nice, and we found that actually the diagnostic quality doesn't drop. It's very, very similar, and actually the patient feedback from it was much more positive, and our DNA rate, along with other variables, I'm sure, but our DNA rate improved massively, because people were able to come in, and you consider that our key range of age is sort of between sort of 60 and 80. That's going to be our median range for CTCs. So, you know, we've not got a young cohort for these. So.
So that's really, really useful. And obviously, again, leads me next on to our next question is obviously there you've removed what could be, you know, classified as an unnecessary step and waste. So can you give us some examples of other wastes that you identified that could be removed and optimize the pathway how you did?
Yeah, so in terms of the bowel prep, obviously we had the Picalax I've spoken about, so it doesn't seem to affect the quality. So as well as not having it for the patient, that reduces a risk there for them, but also the reduced cost of the resource of the Picalax. So we were giving that to virtually every patient, 30 a week. So that's going to be a huge amount of money we're saving. Our bowel prep transit was a very lengthy process, with increased potential for error, and our referral quality, patients not attending appointments on time, or not attending at all, or attending inappropriately prepped or informed. I think these all work really well together. They're all sort of a bit interlinked, like we've spoken before about this being quite an agile project. It's so true. Like I honestly believe the Picalax has affected the referral quality in terms of patients being better at attending because they are not having a Picalax, so they're feeling more comfortable when they're coming in, and it's just far less aggressive. And the same with the bowel prep transit. You know, if something's breaking down partway through, they may still have an appointment, but don't have all their preparations come. So I think they're all really well interlinked. So
yeah, I think so too. And obviously, with removing the Picalax, like you said, another example of an improvement that we can see is it's actually made that ICM referral form for our referrers so much easier. Now we just have two bowel prep methods, obviously gastrografin, and then I know there's an alternative for patients who can't have contrast, but instead of there being a plethora now of different bowel preps, that's it, yeah, a plethora of different bowel preps that they could have. Now there's only two to select from, so it's going to increase, you know, the ease of which somebody can refer for CTC as well.
absolutely, yeah.
So I guess we now need to know what you actually did. So how you actually installed the change and what steps you took. So can you just tell us a little bit about that, please?
Yeah, so there's quite a few things we've done, which they've all been really positive. So one of the more recent ones is having 3 CTC radiographers um, in the room. So this increases capacity to a potential 7 CTCs a day. I mean, I think we could move to 8 at some point. I think it's with those 3 radiographers, it really does allow for different jobs to be done, consenting patients outside of the room rather than inside the room, which does give us extra time with the patients on the table, which is really good. I think, especially from our patient care point of view and sort of reducing anxiety and things like that. We've made an appointment of Louise Butterfield as our dedicated CTC bookings clerk, and having a group, like a colon group chat on Teams as well, has increased our communication and improved slot utilization in the event of like a last minute colon cancellation. Obviously, if a colon cancels last minute, we're not able to fill with a colon because of the prep required, but it has improved so protecting those slots. It's also improved DNA rate. Sometimes patients will ring with a very straightforward question for us to answer, such as, can I still eat chocolate? The answer is no. Although this may seem kind of trivial, it would have caused the DNA in the past, but a simple answer to this question means that the appointment remains. So, I mean, I think it's all of these things, but especially having Louise has just made such a difference for us.
Yeah, definitely. And I think, yeah, it's such a valid point. You know, she's brilliant at what she does. The question I'm going to ask you here is what I know this is pre-recorded, but I guess what a lot of people will be thinking, which is why did you need the extra radiographer to get the extra slot? Can you just tell us how you're using that person?
Yeah, so the way that we visualize it is to have 3 radiographers. So one radiographer will be doing the tubing with the patient and potentially consenting. So they'll consent the patient outside of the room. They'll bring the patient in. They'll be with them that whole time. They will then they'll have talked to them about the contrast and all that sort of stuff. They'll tube the patient. They'll go into the room. Another radiographer will scan them. Meanwhile, the 3rd radiographer is then outside consenting the next patient, and then everyone moves around one. So it means that we can reduce our appointment times from 40 minutes down to 30, therefore fitting in more patients and not affecting the patient journey and not giving them any less, not reducing in their patient care. So
yeah, that's such a good answer. That's such a really, really valid point that you've made there. And I guess as well, on the consent, it probably just feels so much nicer for a patient being consented outside of the room rather than in the room when you're practically hooked up, ready to go.
Absolutely. I mean, technically, I think the CTCs are classified as an interventional procedure. So we should be consenting. We could be consenting outside the room. Obviously, logistics don't always allow that, but we sort of make sure that patient isn't, on the table ready to go before we're consenting. We try and give them as much information as possible because I think it's important, and ultimately patients are scared, and we don't want that.
No, exactly. Yeah. So obviously, with all these amazing steps that you've put in place and all the hard work that the colon team, yourself, Louise, bookings, everybody's been doing, can you tell us all about the results? I mean, we've got some before and after graphs here, which are coming up on screen. And the difference between them is quite substantial. Obviously here, as we spoke about at the beginning of the call, we've got where we were doing well, but that was with a really low demand that was just coming in just after was switched on after the COVID off, if you like. And we could see the influx of demand coming in. And now, obviously, it's a completely different graph. So do you just want to talk us through that a little bit, please?
Yeah, so we were able to improve our capacity breach by 14%, which is something that I'm really, really proud of. And and the compliance of our 2-week wait target by 50%. So I think as well, I don't want to bang on too much, but having Louise available for this means that we have continuity throughout the week. Booking a CTC requires much more knowledge than a regular CTC scan, rather than a CT scan, I should say. And Louise has honestly become an expert in this. And I think that being able to fill these slots, it's a really slick process now. And that has definitely contributed to our improved capacity and our reduced DNA rate.
Yeah, definitely. And obviously, I know we've said 50% improvement here, whereas obviously people are going to see it and see that some weeks we were 0 and some weeks we were 100. So why is that not 100%? But obviously this data comes in weekly. So it's very difficult, isn't it, to say that we've made a concise 75, a concise 100. But also, do you just want to explain this little dip here? Because obviously when we're looking at an after graph, it's sometimes a little bit challenging to see something where you're below your target line, but obviously there is a very good explanation for that, isn't it? So just want to let our audience know what that is.
So so we're around Christmas there. So as you can see, the referrals would have come in for that period would have been around the Christmas time, around the festive time. It's the old adage, people don't want bad news at Christmas. People want to enjoy themselves and eat food and have fun. They don't want to be on restricted diets or be coming in for invasive procedures at that time. So dips like that, and as well as the fact that obviously all of our numbers are a little bit skewed by COVID as well, because obviously are we in lockdown? Are we not in lockdown? It's, the last couple of years have been difficult in that respect.
Yeah,
so
definitely.
I think it's we're always going to get that little dip at Christmas, especially in something which is reliant on a diet sheet and a dedicated diet, and are not a very pleasant situation.
Exactly. Yeah. So that's perfect explanation. So I guess my last couple of questions, I'm conscious of time, but how did you make this stick in a project which is so challenging and has been so challenging for so long and has had multiple improvement attempts? How are you making it work, I guess, is the question.
I think it's fair to say as well, a lot of the support of people has been really great. We have had a lot of support of this process as it's gone through, which has been fantastic. But specifically, every Friday there's a PTL meeting, and we speak to Kate Hocking, practice coach and CT rota master, who will find days when we can have 3 CTC radiographers in the scanner, so that Louise can then book 7 patients on that particular day. The waiting list is it's quite a dynamic process, which is quite nice. So the waiting list will be evaluated at the PTL, and if the demand has been quite high, then we'll request an increase in the 7-day, 7 patients a day sessions. So we are able to increase that if it demands. But it's nice that we're quite reflective and reactive on that, depending on what demand is like. So
yeah, definitely. I think that's a really, really effective way of doing it. You're pausing to check every week, you're keeping the focus on it, and you're not just letting it become something that is assumed is going to happen and then people are stepping away and it can dip. So yeah, that's a really good way. So obviously the next steps, we'll just briefly talk about this. So this is a planned future improvement. This is a prep project, and I'll hand over you, but obviously we know this has been massive and a really big piece of work. So if you want to explain a little bit about this.
Yeah, so we're still not quite there with in this respect, but this is because currently EPMA doesn't exist within outpatients. We are awaiting what could be considered an electronic prescription from pharmacy governance, and that all seems positive, but still yet to be. I think that's in April, I believe.
Yes. Yeah.
And this has not been an easy part of the process. Complex stakeholders, multiple process maps, And previously, Kerry, I'm sure you'll remember, at the point of going live, we did have to scrap the process and start again.
Yeah, definitely. But as we've just spoken about briefly, you know, I think, like, you know, we've joked about it and said, but I do believe everything happens for a reason. And the process that we've got on the right here, which is the process we're suggesting, actually is fewer steps in the project we wanted to go live with. So
Yeah,
yeah,
absolutely. I think that perhaps it's happened, you know, it's all happened for the right reason. And actually, our proposed new process that's going to pharmacy governance actually is superior to the one that we proposed going live previously. So
yeah,
yeah, I think
definitely.
it's all been very positive, and yeah,
I
it's
think so
great.
too. So obviously, the closing question I will ask, which is the same I ask of anybody I've taken through Practice Coach, and I know is such a vital question at Report Out, is how do you think the Practice Coach methodology and the improvement methodology we used help with your project?
I think the key thing for me is has been working with people and knowing that people are it's quite in the same way that our project is very agile. I think it's fair to say that there's human factors involved in the improvement cycle. So, and just as we mentioned before with the our previous, you know, idea for how prep was going to be given, it's important to think of like a continuous improvement culture. So we thought we'd had it there with that, didn't quite work out, and actually we've got a better one now. So just because we think we've got it improved, and you know it's at the point where we're ready to go, doesn't mean it's not going to be changed in the future, and doesn't mean we can't improve on what we've already improved on. You know, so I think it's, you know, it's really good to have sort of step back and think like a little bit objectively about what's happening, rather than, you know, sometimes you get a little bit too close to a project and you just have to sort of you know, step back and think about it. So yeah, reflect on your practice a little bit, I guess.
Definitely. So that's such a good answer. And I think obviously from myself taking you through the process, you've been a model student throughout. You've been really, 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 really helpful, really, really responsive, but also it's just your dedication to the project as well. I think you didn't have an easy one. You still don't have an easy, you know, challenge ahead of it, but you're staying persistent with it and you're doing really well. And I know that you'll be so happy to have your practice coach certification
Absolutely.
through
It's
the
great.
process. So yeah, thank you for taking the time to speak to me today. And on that note, I will hand back to Richard.